Okay, so can I ask a question? Who are you guys exactly? Who is the group exactly? Are they all working on different projects?
It's
right?
basically everybody at the DCRI. So you have assistant directors, you have project leaders.
And everyone is working on a different project.
And everyone is working on different projects, not necessarily part of the infectious disease group.
Got it.
But there are a fair number of people, either here or on the phone, who are listening, who are working on ID projects.
Okay.
Right now, the bulk of the projects in the ID, we have a bacteremia study we're going to be working on. We're doing a lot of Hep C trials. And, for many of the people who are clinical, hepatitis C follows the model to a great extent of where HIV was in the late 90s. And one of our fellows, Susanna Nagy, is an infectious disease person with HIV experience. And a lot of the Hep C trials, a lot of the Vertex studies that some of you worked on, they're actually looking at Hep C HIV combination therapies.
Throughout the nation, basically, Hep C is sort of more...
That's kind of where we are.
Co-infection clinics are becoming more and more prevalent just because the percentage of people who have HIV among the Hep C population is so large that really a co-infection clinic in a combination of care has become much more beneficial in terms of that patient, because really it's a combination of care, and if you have one provider that is able to provide both. And obviously everybody, well, if you are on the Hep C stuff, you have a ton of side effects with those medications, interactions with HIV meds. So it's becoming more and more important to just sort of actually have an isolated co-infection clinic for people who have HIV and hepatitis C. So I'm just going to give you a very broad overview on HIV. Even if you're not working on it, it's a public health issue. It's an interesting topic, and it's sort of evolving as we go forward in this world. And, unfortunately, it's evolving in a really great way, in a way that it's becoming kind of a chronic illness rather than a disease that kills people. So this is let's see if this works. Does it? No. Oh, okay, whatever. So is there a pointer that works? No. Oh, here we go. Okay, so this is a budding HIV virus coming out of a CD4 cell, a macrophage, one of the human immune cells. So the CDC is updated up to 2007. So I'm using their slides because it's really our most updated data that we have. Every year it's we're just a few years behind in gathering data. So the estimated number of AIDS cases, as you can see, when AIDS was first discovered, which was in 1984, dramatically rose, and has really since 1993 on. The first AZT came out in the early 1990s, and with AZT and HIV medications, you've had a dramatic fall, obviously, in the number of cases of HIV. And the reason that the prevalence of HIV is going up is not because you're having more HIV, but because you have more people living with HIV. So you got tons of people, the number of cases that are coming are probably leveled off, but the number of people actually living is going up and up and up. And the deaths, as you can see, are going down. So this is sort of the trend of HIV over the last, 20 years. So I lied to you because that's AIDS. I'm sorry. So that's the point. So these are people who actually have AIDS. And the definition of AIDS, as you can see, in 1993, even though HIV was sort of first cited in 1984, it took a very long time really to create a full definition of what AIDS is. And AIDS is HIV plus one of these things. And that's a CD4 count of 200 or an AIDS-defining illness. And people, if you've heard of AIDS, things like Cryptococcus or PCP or Toxo or Mycobacterium avium complex, you might associate with HIV, these sort of rare diseases that really actually the United States didn't see until until AIDS and HIV became prevalent. But other things, such as strange things that you might not think of, are also in this definition, like cervical cancer or Salmonella septicemia, other things that are even disseminated tuberculosis, so things that aren't directly related to having a low CD4 count, but more related to just your immune system being down. And cancers are certainly up in terms of HIV diagnoses because of just immune dysregulation in general. So this is the prevalence of adults living with HIV, not AIDS. So any CD4 count, really healthy people, anyone with HIV as a diagnosis in 2007. And as you can see, really the reason the white states, California, where you actually have a high prevalence, they don't collect data. I mean, it's very strange. And I think that was because when there was such a stigma when AIDS first came out, there was a lot of lobbying groups to try to not collect data, not collect names. And California was kind of on the forefront of that. And at this point, I don't know what the point is, to be quite honest. But anyway, so we have data for the other. And as you can see, really the East Coast and probably the West Coast, if they collected data, would be the prominence where HIV exists. In the middle is quite low. But the rates are kind of astounding. It's per 100,000 people, and you get, in Florida, 256. So there's still quite, a number of people living with this disease. So this is transmission. So I guess, everyone sort of thinks of it as a male-to-male sexual contact. You have to remember this data is for the United States, okay? So, male MSM, male sexual male contact, was sort of the predominance in the beginning, and it has also gone down. Everything is going on. The one thing that is going up, and we're seeing more and more of, is high-risk heterosexual contact. And so that's becoming, especially in the United States, a really big problem. And particularly, actually, and we'll kind of get into it later, it's becoming a problem for women. So the number of heterosexual contacts are not really male heterosexual contacts, male-female, but really an acquisition of female partners of men who are infected. And that's becoming a bigger problem in the United States, even more as we go further. Just to let everybody know, although the predominance still remains MSM in the United States, if you took a global look at HIV, greater than 80% of HIV acquisition is actually through heterosexual sex, and that predominantly is in Sub-Saharan Africa, and that is a heterosexual predominant disease. And right now, if you looked at acquisition of HIV, 50% of acquisition is females. So the disease that we sort of think of that exists in the United States is really not the way to think of it globally. It's a very different global disease. It's okay. So I guess this is just another kind of way to look at this. I mean, this is just 95 to 2007, and high-risk heterosexual contacts going up, and injection drug use on both these scales are actually going down. I mean, that's just... unfortunately, injection drug use in Asia and some, like East Asia, like Thailand and stuff, that's kind of going up, and their HIV prevalence tends to be directly related to IV drug use. So HIV, like infectious disease in general, is a disease of your environment and choices and what's around you, which I think is what's kind of interesting about infectious disease in general. It's who do you sleep with, what are you eating, where do you live, and who do you hang out with, And that's kind of what happens with HIV. So this is racial, so looking at the racial profile. So the number of AIDS cases among adults and adolescents by race, and again, it was predominantly a white disease, and that was a white male, primarily MSM disease. And as we go forward, more and more we're seeing black, African American population sort of really getting, the acquisition is becoming higher and higher amongst that community. And as we'll see, a lot of that, again, is African American or black females in the United States of America. Okay, so just another thing, as sort of, white MSMs are kind of going down in America, sort of more black, African American, heterosexual acquisition is going up. And it's really where I think we need to sort of address, because our attention, lobbying-wise, political-wise, and financial-wise, in the beginning was very much a lot of like HIV, AIDS, gay activization groups, which was wonderful. And at this point, I think in terms of political lobbying and in terms of where our, epidemiology needs to focus on, it's really a different group at this point. So, again, this just shows you is just that in terms of population, so again, 12% of the population in the United States is African American, 48% of AIDS is African American. Like, this is becoming a big problem. So, females, it's going up, and the percentage of HIV/AIDS among female adults by transmission is predominantly all heterosexual sex. Very few, 16% injection drug use. And again, if you look, you know, the female population, 14%, you have African American in the female population, but their acquisition is 66% of the new acquisition of HIV/AIDS. And in 2003, you were 20 times more likely to acquire HIV if you were a black woman versus a white woman in this country. And there is no data to talk about necessarily why. There are certainly some things. There was a book written in the I think in late 90s, early 2000s by an African-American male who considered himself heterosexual but was, quote, down on the down low. And there was a large exposure of a group of sort of like culturally unacceptable to be homosexual, and that there's sort of a large number of groups. This is not proven by statistics or epidemiology, but sort of a thought process of, is there a cultural aspect to why perhaps there are MSMs, black MSMs, who are also having sex with women, and there's more high-risk behaviors because of sort of lack of acceptance, because lack of acceptance leads to lack of care in terms of using condoms and things like that, and that could be one of the reasons. Unfortunately, because of socioeconomic issues, there is a larger incarceration percentage for men amongst the African American communities in this country because of socioeconomics and poverty and all sorts of reasons. And incarceration, you're 5 times more likely to come out of jail with HIV than just being in the regular population. So that's another sort of impact on that community that is, you know, is problematic. And unfortunately, that's because of devastating things that happen in jail, such as rape, but also things such as, you know, IV drug use that's going on in jail that's not protected, that people, you know, have to sneak, and therefore you're using, you know, dirty needles and things like that. So it's just becoming a problem, and primarily it's becoming a problem for African American women who are having heterosexual with partners, you know, people they sort of determine as their primary partners. So the South, which is where we live, the Southeast definitely has tons of pockets of HIV, and if you look at North Carolina, it's the cases here per 100,000 are pretty large. But if you look where the predominant cases are, we're talking Texas, Louisiana, and Florida. And you can make a number of assumptions of why that might be, but primarily I think the thing to recognize is that still HIV tends to be a disease of urban areas. And that if you look, you know, the CDC defines urban areas by population. And if you look at populations that are greater than 500,000, I think it's like, you know, I'm not sure, per land or per square foot or something. You know, the predominance of cases, 80%, you know, greater than 80% are in there. And so if you're thinking of even in the South, where is the predominance? It's in places like in Texas, urban centers, in Miami, or in New Orleans, but urban areas.
So, Brianna, do you think that is because patients gravitate to urban areas for treatment?
Okay, so, you know, these are all difficult questions because they're not supported by data, and you end up making cultural generalizations, which are always problematic. But I think, you know, the demographics of HIV in this country is still predominantly MSMs who are predominantly not accepted in very rural areas and tend to migrate into urban areas. So I think that's probably a large reason for it. But I mean, I'm sure there's a number of other factors, but certainly care is probably better in larger urban academic centers. But at this point, I will say HIV care has really disseminated pretty well, though, throughout most of the country, and there's a lot of specialists even in rural areas. So that was all the U.S., and just to get a global sense, there's a lot of people with HIV. You know, and this is in 2007, 33 million. New HIVs, 2.7, so this is people living prevalence versus new cases, and deaths is, 2 million a year. So it's a humongous, it's a pandemic, as we all know. And if we look, the predominance is in Sub-Saharan Africa, 22 million people, which is significantly more than even if you look the next step, which is 1.7 or 1.5 million in Latin America or Eastern Europe. So we got a huge, huge problem, and for a number of reasons. So again, if you just want to look at it sort of in terms of color, the predominance, and it's not on all of Africa, it's really Sub-Saharan Africa. So the southern aspect of Sub-Saharan Africa is carrying the burden of our global HIV epidemic or pandemic. And then when you look at the east, I mean, India is kind of like in the east, the other place where there's a lot and a growing number of HIV cases. So over 7,040 new HIV infections a day, and more than 96 of these are in low and middle income countries. We don't make up the majority of these problems, although, you know, we need to obviously focus on it. A ton of these people are children, which is a problem we don't really have as much in the United States. And 50% are women, and 45% are even among people, you know, less than 25 years of age. So we got a young disease, and we got a lot of child acquisition, which, you know, I'll get into a little bit later, but we don't have as much. We have our teenage population of AIDS is becoming really small in this country, and that's essentially because we're pretty good at getting people hooked into prenatal care. And if we don't get them hooked in for extensive prenatal care, we're very good at during delivery, pre-delivery, post-delivery, and with the infant. We have found that giving just drugs or HIV drugs around this time period has basically reduced transmission to about less than 2% vertical transition from mom to daughter or mom to child. So we're actually fairly good at that. The problem is when you're going to developing countries, you know, and they don't have the services, the money, that they are not even able to afford the 3 drugs that you need surrounding that treatment. And they came up with, you know, a drug, nevirapine. They can give once to the mom, once to the baby, on a $4 a day budget. I mean, $4 for the United States. It's still expensive, but they're able to do it. But that reduces your transmission from what it would be to 50%. So it's good, and it saves a lot of lives, but it's not less than 2%, which is what we're able to accomplish in the States. So there's a problem. And just, you know, real quick, so 10% of the world population lives in Sub-Saharan Africa. It's approximately 64% of the world population living with HIV. And all countries in this region have an HIV seroprevalence rate that is about 5%, some as high as 25, which means if you're sitting in a room, 1 out of 4 people have HIV. So that's terrible. Mostly related to heterosexual transmission, and little is known about the overall prevalence of male same-sex behaviors in African societies, which is, there is sort of a surge of research because, that said, we do know that there is a higher acquisition from male to female sexual partners with the HIV strain in Sub-Saharan Africa. And whether that's host genetics or strain genetics, I think that part is yet to be determined. But we're obviously just based on culture. I mean, all this stuff is on questionnaires, right? So obviously your acceptance of saying who you have sex with is gonna widely affect our ability to collect data that's accurate. So, you know, they're looking more and more into this. What is a population? Are we missing a large population in African societies? You know, and just to sort of read it, so I always like to say this, and it's a little crass, but so being a homosexual man is not a risk factor for HIV. The risk factor for HIV in general is mucosal breakdown during sex. And if you participate in anal penetration, then you'll have an increased risk of mucosal breakdown. But it's just, you have to be participating in that kind of, in that sexual activity, not just sort of, you know, in order to have a higher risk of HIV. I just like to say it because it's about a specific act rather than, you know, a large demographic of people. So it's terrible, the leading cause of death in Africa. This is a pretty old slide, but it's 20%. So, I mean, it's the leading cause of death. And I think this is an outstanding slide, and this is the life expectancy in 5 African countries, the worst of which of the HIV pandemic. And I mean, first of all, none of them have great life expectancy, right? So in 1970 to 75, pre-HIV, you're talking 50 to maybe 60 years old you're going to live to. Well, HIV hits, right, and this is dramatically dropped. Like, and if we look at Botswana, I mean, we got a life expectancy of 35 now. And this is directly related to their HIV. So it's pretty terrible. they've also done literature, which I don't have a slide here, their TB has gone through the roof. So the amount, you're 10 times more likely to get TB and disseminated TB. And obviously, you know, we all know that tuberculosis is a problem in developing countries, and because of HIV and TB, and also malaria. So not only does HIV kill these people, but they acquire very difficult co-infections like TB or malaria that they're unable to fight, nor is there drugs to treat. And so there's just had a dramatic toll, toll on these people. So what is HIV? Yeah.
People have questions. Do you have questions, anybody? Okay. Because you were going to a different section.
Yeah, no problem.
Thank you.
So that's kind of like who has HIV. And what is HIV? It's a complex virology that I don't pretend to know everything about, but this is the HIV viral cell, and it is a RNA virus, and it has 2 copies of RNA. I can't seem to get this. Here we go. Of RNA in its nucleus, and you have a cell membrane that, and it uses a reverse transcriptase, which we'll get into as its enzyme of production. It has a cell membrane that has a GP120 glycoprotein and a GP41 transmembrane glycoprotein. And these 2 surface proteins will come into play later when we talk about how it infects cells. So it's a double-stranded RNA virus. All of our genes are DNA. And it uses reverse transcriptase to replicate, and it has very important sort of cell membrane proteins. So steps in replicating an HIV virus. We know them very well. And the reason we know them very well is that in order to make drugs, we have to interact or affect some of these, basically drive a breakdown in these processes. So you attachment and entry, and then, you know what, maybe I can just kind of go down. Okay, well, yeah, so I'll talk about attachment and entry. So attachment and co-receptors. So this is important. So you got your HIV virus here, and sometimes it works, and sometimes it doesn't. Anyway, so your free HIV virus, and you have your protein, which is the blue guy there, and it goes on to your T cell. Okay, a T cell is a lymphocyte. It helps fight infection, and has CD4 as a receptor on it. Okay, just like, well, I'll get to that later. But anyway, so your GP120 protein hooks onto your CD4 receptor. It then causes a conformational change in your GP41 protein, which is the green guy, and the green guy makes a conformational change so that it's able to bind to another co-receptor on that T cell. And that co-receptor is usually a CCR5 co-receptor, but can be a CXCR4 co-receptor. And that's very important for medication, but also because, some viruses have tropisms for CCR5, where all the viruses enter through a CCR5 receptor. And some viruses use both CCR5 and CXCR4. We have a medication that is a CCR5 receptor blocker. And that's wonderful. So it protects entry into cells. And that's a new medication called Mavorixafor. And the problem is you got to make sure, you got to test that person to see what kind of HIV cell they have. If they have an HIV cell that uses both receptors, this medication is not going to work for them. The interesting thing is most people who originally get infected by HIV, their HIV is all CCR5, and it just goes through a CCR5. But as they have HIV over time, their HIV will develop ability to use different co-receptors. The other really cool thing is there's a major population, there's a small population who have this weird genetic mutation in where their CCR5 has a genetic mutation. These people are essentially benign to the acquisition of HIV. So there's a population of people who know they've been exposed to HIV, who have practiced in risky sexual behaviors, and they've taken these people and they all have this CCR5 genetic mutation. So we know that this has got to be key to helping prevent this disease forward, because you got a population who basically can't get HIV, and it's all because of their CCR5 genetic mutation. So this is the cell. So basically, this guy, that's one you can't see. All right. So like I said, you go in and you enter through those two proteins, okay? And you got an RNA. And you use reverse transcriptase, really, to make DNA, okay? So then you get unintegrated DNA, and it moves into the nucleus. By the way, this cell is our cell. It's a human immune cell. T cell, macrophage, dendritic cell, some kind of immune cell this guy decides to hook in on. So one of the cells that it hooks in on is a dendritic cell. Dendritic cells are immune cells that live on our mucosal surfaces. So that is why mucosal surfaces genital surfaces are mucosal surfaces. And so that is why, sex is a predisposition to acquiring this disease. So anyway, you got your integrated DNA. It goes into the nucleus of our human cell, and then you use something called an integrase enzyme, and it integrates the viral DNA into our DNA. It then goes through transcription, which it makes mRNA, messenger RNA, and this messenger RNA, this is whatever, but anyway, it goes through translation, and the translation makes little proteins, okay? So you got, now in the cell, you got these long strands of messenger RNA, you got long strands of viral DNA, you got long strands of proteins. All these little guys come to the edge of your cell, and they're like, all right, we're ready to be bundled up into a virus. And they basically bud off, and they take with them some of the human cell membrane. Then our CD4 dies, which is the biggest problem with HIV, not having CD4 cells. It explodes, and little virions come out. That virion has not matured. It then has enzymes called proteases that take the big, long guys and splice them up and make it into a functioning, mature virus. And the reason I bring up all of that is because later, every single one of those steps is how we've acquired all of our new HIV medications. That's it. So this is kind of gross, but this is all the HIV budding off a CD4 cell. So that's not good. Okay. So it's not just, yes, ma'am. It is.
Okay.
It is.
It's not a cell in and of itself. It's a receptor on a T cell.
It's a receptor on a T cell, a specific type of T cell that because of its receptor, we call them CD4 cells. So it's just like, that's how we name it, because of its receptor. Exactly. So we have CD8 cells, right, which I'll kind of get into. CD4 cells tend to be a little bit more of a memory cell. CD8 cells are cytotoxic, so they just go in and kill. So they all have specific jobs, but they all are lymphocytes, and they're T cells, and there's just a certain type of T cell. Yes, ma'am.
What's the prevalence of the CCR5 genetic mutation? Do you know?
You mean that group of people?
Mm-hmm.
I don't know. It's really small, but I don't know the prevalence.
And it's not more prevalent in any particular world population than another?
I don't know the answer to that either.
Okay, she always asks tough questions.
That's okay.
I have a master's in genetic counseling, so I always ask about genetics.
Really? I need to learn. I need to go back and learn genetics. So the immune, even though it affects it enters through CD4 cells, T cells. It can also enter through macrophages, which is another part of our sort of innate immunity. Our immunity attacks immediately, not our memory immunity, which sort of is like our B cells, and you make antigens and you whatever, the things that hang around our bodies forever and ever and ever. Like that's not this. This is our innate immune system, that the things that come immediately you get infected and they flourish in. Okay, and so it can actually affect really any of those kind of cells. So HIV typically enters through a dendritic cell of the genital mucosa. These are antigen-presenting cells, and they can present HIV to cytotoxic CD8 cells to help control the infection early on. So the dendritic cell can sometimes say, hey, CD8 cell, we got a foreign thing, and that CD8 can eat it. And that's how our body tries to keep HIV under control. The problem is that those antigen-presenting cells says, shoot, we better get to the lymph nodes, we better get all over the place, because I need help. And then when they go to the lymph nodes, these HIV cells, infect all of the CD4 cells that are in the lymph nodes. So it's sort of like a really, it's like a, a cycle that perpetuates, unfortunately, HIV production. So that said, to do this, dendritic cells migrate to lymph nodes. HIV has a chance to infect them. HIV is unique, and then it selectively targets and infects expanding CD4 cells. So if your CD4 is lit up to work, that's the one that the HIV goes in. So it's sort of this paradoxical surge. If you get infected, you get viremic, meaning viruses throughout your whole blood system within 5 to 30 days, and it kind of goes everywhere. Within the first weeks of infection, there's massive loss of T cells in the gut. We have tons of lymph cells in our gut and massive loss of CD4 cells in our gut. This is why there's all research on sort of gut flora in HIV and what happens to our gut and why is there diarrhea and things of that nature. And then soon there's a loss of peripheral CD4 cells, which is kind of the hallmark of this entire disease and what we measure to see how patients are doing. It doesn't want to go forward. Oh, here we go. So the only thing I want to mention here is that it turns out that some of these infected C cells are memory cells, and they can kind of not be activated and hide the HIV. So what they did is they've looked at populations where really early on they gave HIV meds, and these people were undetectable, okay? And they know the number of, like how long it would take for all your migrating cells to die, HIV cells to die. And so then, despite all of that, besides waiting all that time, they would take biopsies of lymph nodes, biopsies of spleen, and in multiple cells they would still find hiding HIV cells. And so the problem is all of this, the fact of the matter is, we have an entire body where almost everywhere has immune cells, macrophages, and a lot of these cells can take in the HIV and not die, kind of go into a hibernating state where they're sleeping and not producing, and then years later these cells can wake up and start producing HIV. It basically makes it impossible to kill all the HIV off with HIV medication itself. And basically it makes HIV a chronic illness unless we can prevent it, get a vaccine for it, or, I'm not sure what else to do, prevent the very initial surge. So in the beginning, you'll see that the virus surges, and your CD4, it takes kind of a while, like this is months, even up to a year before you start kind of getting a decline in your CD4 cell. So really what ends up happening is in the beginning, when you first get infected, your body goes nuts, kind of trying to control the infection, and you get a surge of viremia. And that time, people present with flu-like symptoms. Sometimes people don't even have symptoms. They have no idea they're infected. They have a little achy, they're a little flu-like, they're feverish. They don't think anything of it. Then that viremia goes down and kind of stays, at a neutral state. And then what happens is your CD4 cells kind of start to dramatically go down over time. And the progression to AIDS, which is a CD4 count less than 200, where you're at risk for a lot more diseases, is really, they're finding related to that initial surge. So if you look at people who in the beginning, depending on their these are viral loads, so viral loads of 36,000 versus viral loads of less than 5,000, their progression to AIDS is much sooner. So a majority of people don't progress to AIDS like if they never get checked, which is why we want everyone to get checked. But if they never get checked, the first time they show up in a hospital with PCP pneumonia or Candida throughout their body or something is around 9 to 10 years after they were infected. Some people who have this massive surge in the beginning, it's closer to 5 years, and it's a direct linear relationship. So the reason I bring that up is twofold. But one, just to show the diversity, but also there's a lot of controversy of when to start HIV medication. And because of this kind of supports starting it early. And we don't. If you come, I have HIV, and your CD4 count, is still all the way up here, you're in that 6-month range, right? Because you got tested, we got you in early. That's a public health thing. We're like, let's test everyone. So we got you in early the first 6 months. Your CD4s are completely normal, but you got viral load through the roof. No one at this point probably will treat you, right? because you got drug interactions, and they're going to wait a little bit. And the question is that the right thing to do? If we know that people who have surges in the beginning do poorer over time. And we don't know that answer yet, but it's certainly, part of the puzzle. The interesting thing is your CD4 count has really nothing to do with how fast you progress. So once you get, basically, HIV affects every single bit of our bodies. And primarily, when you get the really bad stuff is when your CD4 count is low, when you don't have T cells. And you can get toxoplasma, strange infections, fungi, molds, yeasts, viruses. These tend to be the infections. You are at risk for bacterial infections. However, our B cells tend to be our sort of memory B cells, tend to be kind of our fighters against bacterial infections, and although they're deranged in HIV, they're not low. So you're more likely to get infections that rely on innate immunity and CD4 cells, and these are weird things like viruses and fungi and things and parasites. So you get massive breakouts in herpes, or you get CMV, and because of the derangements, you get cancers. You have a much more increased risk of cancer, because cancer is an immunologic breakdown, essentially. Okay, so this is kind of as your CD4 goes down, what you're at risk for. And if you look at lymphoma, it has nothing to do with your CD4 count. So cancers, you're not more at risk if your CD4 count is low with cancer. It's how long you've had the disease. Granted, people do think that the longer you've had CD4 counts that are low, the more likely you are to get a cancer. But it's a little bit more a relationship to time than it is to acute CD4 levels. And that's the same thing with CNS disorders and sort of just in general wasting. People get HIV dementia and other HIV CNS disorders. And again, a lot of times it's just length of time. I do think that CD4 has some relevance, but the length of time has a greater impact. TB is a huge thing. You're 10 times more likely to get TB or, to manifest as reactivated TB. And that's it, really. Okay. So that's kind of HIV as a virus and what happens to your body. You know what? I should mention, I should have had a slide in there. So the other thing that HIV does, because there's a sense that it's a pro-inflammatory, it also has effects on heart disease. So for sure, we know that people with HIV have greater heart attacks, greater heart disease, greater lipid disease problems like increased dyslipidemia. So HIV is kind of like smoking. It really is a problem for everything. You can't, well, I mean, it's not like smoking, but smoking's a nightmare. But, smoking affects every organ. You end up with bladder cancer and whatever else. But, so HIV really affects every organ, and it's not just infection, although we think of it like that. It predisposes you to a whole number of things that we even consider chronic diseases, like coronary artery disease, dyslipidemia, and cancers. So who gets this disease? Or how do you get it? Blood. It's a blood-borne pathogen, and it's very rare to find HIV in saliva, which is why, in the beginning, there was huge, massive lobbying trying to get people to realize you could shake hands with people, you could share drinks with people, etc., because it's not a disease of the saliva. It's really a disease of the blood. Now, if you are brushing your teeth and you're bleeding all over the place and you're sharing, toothbrush, it's a whole other story. But it really needs to be a blood-to-blood thing. So blood products, since I think 86, have started to be screened, so it's pretty much unheard of. There has just not been a case where you've acquired HIV through blood products. Of course, everybody knows of Ryan White. Actually, it was like Ryan White anniversary, like 2 days ago. you remember him? Anyway, mother to child, like I said, really low in the States, less than 2%, and we're even better than that because we got a lot of people in prenatal care. That is not the case in developing countries. Injection drug use is going down, but certainly that's dependent kind of on where you are in the country and what's going on. So it's fundamentally a sexually transmitted disease. That's certainly true globally, and it's definitely true in the United States. Receptive intercourse is really the risk factor, and the stage of disease, meaning your partner's level of viremia matters. And so from a public health standpoint, if a partner has HIV and they're undetectable, the acquisition is pretty negligible, even if you're having sexual intercourse. Can it happen? Absolutely. But it's dramatically reduced. That is has huge public health impacts and implications. And I'm not going to soapbox, but we just lost ADAP, which in North Carolina is a state-by-state monetary fund for people who are sort of in a low-income group. If you acquire HIV, you get your meds paid for. And we lost that. So no more in North Carolina, if you're a low-income person, will you get your HIV meds paid for, which I cannot believe because it has a huge public health impact. And these people, I mean, there are some people with HIV who are, whatever. They're lawyers and they got, they're like, got everything, every support system. They're married and they're lawyers and they have money and they're great. Fine. But there's a lot of people with HIV who don't have that support system, who aren't married, who don't have their sister or brother living down the street, who aren't, financially able, independent. And getting those people, medications is going to be a real nightmare. So we're already seeing a huge problem with that in the clinic. Because to be below poverty level, it's pretty low to get on it. So you're, again, just as usual, you're missing kind of that lower, middle class kind of people that might have a lot of support problems that need help. So that's, the other thing is concomitant STDs. So, one, they've really, they have seen, although no one likes to talk about it, but there certainly has been data out there that circumcision does help in the acquisition of HIV, and that's probably just because of inflammation around the penis, and having inflammation means a lot more macrophages and a lot more CD4 cells and possibly a lot more possibilities of entry. So there has been, it's a controversial thing because some people want to go around and circumcise everyone in South Africa, in Sub-Saharan Africa, and obviously that carries a lot of cultural problems. That said, syphilis and HSV, not gonorrhea, not chlamydia, so not if you're dripping, but if you're outside, you have a big lesion that's open, you got macrophages and mucosal cells that are open to much more easily being infected. So, and there is a huge relationship, particularly in urban areas, particularly in MSM populations in this country, of having concomitant syphilis, and that will increase your rate of acquisition. So, again, I'm just showing this. So this is in the United States. It's mainly male to male. 71% of men, it's MSM, and then injection drug use. And then for women, it's not all, but primarily heterosexual sex. Other than 16%, there are IV drug using populations. So this is going down, but I will say it's a really difficult population to treat. They're drug addicted. There's not a lot of support system for them. They're not particularly a well-represented, financially funded part of society because they're unwell and marginalized and things like that. So they don't do well, and they get hepatitis C, and they have co-infection, and there's just a huge amount of rates of hep C and HIV in the IV drug using populations, and they have a whole myriad of additional problems. So just mother to child, so in 1,800 new infected babies are born each day. 90% of those are in Sub-Saharan Africa, and the rates in the developed world is really low, like less than 1%. So it's pretty astounding. 20 and 40% of pregnant women are HIV infected. And 1/3 of their babies are infected. And unfortunately, although we have antiretrovirals in the world, we can't it's very difficult to get them there for multiple reasons, and so, you get less than 10% of these people even being offered the nevirapine, the $4 regimen. It's even hard to get that regimen to people. I mean, they just don't have the infrastructure, So it's unfortunate. Whoa, wow. That said, it's effective. Okay, so in the United States, we're getting down to nil in terms of this population. Actually, it's interesting. The whole New York Times had this whole article on HIV teenagers a few years ago because the group is so small. It's like they're almost forming their own kind of like national group because there's just a tiny number of teenagers living with HIV. And I mean young. I mean like 10 to 16-year-olds, not sort of before they start acquiring it on themselves. Okay. So HIV treatment has come a really, really long way and is a major change. It's done so well that it's becoming harder and harder to get funding. To even do HIV. The funding is there, but it's becoming a chronic illness. We're really made a lot of headway, and so some people are forgetting about it. Actually, they're forgetting about it to the point where there's been a recent surge in particularly MSM, young MSMs who have forgotten that this disease is a problem. Because, for a while there was a real decline, and you saw that yellow line, that decline in the MSM population, and that was because of, a lot of times because of fear, and they started protecting themselves. And there's been sort of a recent surge and the hypothesis is that it's just not the same, it does not carry the same weight as it used to, which is unfortunate because although it's a chronic disease, it's certainly pretty devastating to the body. Okay. So integrated approaches to HIV treatment. Let's see if I have another. Oh, I didn't know this. Cool. So this is reverse transcriptase inhibitors. That's the majority of our drugs. So AZT that came out was the reverse transcriptase inhibitors, and this is the enzyme that the virus uses to make itself from RNA to DNA so that it can incorporate into our, in our genes. And we have tons of medications that basically mimic nucleosides and say, hey, look at me, I'm the HIV virus. And then the reverse transcriptase sort of degrades the process. And so that's our primary treatment. And non-nucleosides and nucleotide reverse transcriptase inhibitors. Okay. Protease inhibitors is what came next. So even though AZT was really great, it wasn't until the protease inhibitors came in the early 90s. Yes, ma'am.
Do you dose the reverse transcriptase inhibitors based on the viral load?
No. So the goal of any HRE regimen is to get the viral load to nothing. If your viral load is greater than 0, you're not on the right regimen. So there is nobody who's in care who's taking their medication who doesn't have a viral load of 0. That unless they have resistance. And resistance, although I didn't really talk about it in this, but resistance is becoming a major problem. But because we're getting more and more and more HIV meds, we're able to deal with resistance better and better and better. And that's why we still need to continue to make HIV meds, even though we have such good ones now, because of resistance. Because the higher your viremia, the more destruction you have to the body. It's particularly in terms of cancers and things like that. CD4, it's like you're getting infections. Viremia levels kind of are those chronic where you're really screwing up your immune system with this high level of viremia. So everybody that's in care has a viral load of undetectable, 0. And so there's just like basically a certain regimen and a dose. It's renally dosed, like other, if your kidneys aren't doing no good, then they'll reduce your dose and things like that, but not based on your viral load. So protease inhibitors, proteases at the very end when that little virion buds off and then the protease inhibitors cleaves things to make it a mature virus, that's where the protease inhibitors act. And they are what really has made the dramatic life-saving change in HIV. And they came in the early 90s, and there's been a number of them. The only thing is these tend to have a side effect of increasing your lipids. And so a lot of people on protease inhibitors have to be on like Zocor or Lipitor or some sort of lipid-lowering agent, but it's a pretty low price to pay to have an undetectable viral load and CD4 counts, in the 500s, 600s. So entry inhibitors, that's what I told you about the CCR5. So there's that co-receptor, and we have CCR5 receptor inhibitors. But again, you have to check that person to see what kind of virus they have. Because if they have a CXCR4 co-receptor virus, well, then forget it, because it's not going to work. 50% of people, though, are able to take that drug, and it's a really damn good drug. Like people who do HIV care, which I'm not quite there yet because I'm not in my second year where all my patients are HIV, but, they give drugs, and they have them come back, and, 3 months later, you went from viral loads of 200,000 to none, on these drugs. So it's a really astounding thing. It's exciting to be an HIV doctor because you got a sick person and you make them really healthy. Okay. Oh, the integrase inhibitors, I'm sorry. So the integrase, again, is the enzyme that integrates the DNA virus or that pro-virus into our DNA. Okay, and so there's raltegravir is a new drug, and it's an integrase inhibitor. Again, a very good drug with less side effects. So this AZT that first came out, which is reverse transcriptase, it had terrible side effects. First, we were giving it at doses that are like 10 times the doses we give now, and we had no idea. And people were sort of living, but they were like anemic and, having diarrhea. They were just having major problems. Okay. Maturation inhibitors. I don't know what that is. Why? I think that I really actually don't know what that is. What is a maturation inhibitor? Oh. No, I don't know what that is. But I will tell you, there's something called Fusion. And Fusion is a new medication. It's unfortunately injectable, so nobody likes it. So it's really used as kind of a last-ditch attempt. When you have tons of resistant virus and you got nothing to do, you put someone on Fusion. And what that does is, remember I told you there's a GP120 protein that hooks in, and then it makes a conformational change, and so your GP41 can hook in and you can add to your co-receptor. That blocks, it attaches to the GP41 and won't let it move. So once you hook on, you're just stuck. That HIV virus can't move anymore. So that's what the Fusion does. It's just I guess its properties are such that it's only, they cannot get it to be a solid pill that is oral. It just has to be dissolved, and they have to inject it. Or maybe they can't get it absorption in the stomach. It has to be something like that. Oh, so here we go. So you got your nucleoside reverse transcriptase inhibitors, you got your protease inhibitors, Fusion, CCR5, and integrase, and you can see this is when this started, AZT, 87, and this is when you started getting your protease inhibitors, which really kind of changed the whole face of HIV, and then as we go, we're getting more and more. And this one just came in 2007, Maraviroc, CCR5, which is kind of cool because it's really a good drug, a really good drug with not a lot of side effects. So we get easier, more potent, and less toxic therapy. This is what people used to have to take that. People now take Atripla. They take one pill, has 3 drugs. You need 3 drugs to treat HIV. It's called a backbone. Well, whatever, I can't remember now what the whole, but whatever. You need 3 drugs, and usually it's like 2 nukes and a protease inhibitor, or some very active one, and then 2 other drugs. And that pill, Atripla, combines all 3 of them. And they're coming out with more and more of these. So less and less we're going to need big-time pills. People take 1 pill, they take 3 pills. Yes, sir?
So for people who basically successfully been treated, and they may be alive for 10 years after diagnosis, they need to take currently like the single pill with the triple therapy for the rest of their lives?
Yes. Yeah. As soon as you stop that pill, their virus load goes up. And the way we know if they're compliant is literally taking their viral load. And that's why we say to them, unless they've acquired resistance. But I'll tell you, it's hard to acquire resistance without being non-compliant with your pills. It's not so bad with Atripla. If it's all in 1 pill, if you stop it, you stop all 3. But when you're on 3 different pills and you're totally randomly taking them, your virus starts to mutate. It starts to confer for one mechanism versus another, and you acquire resistance. Unfortunately, nowadays you can get infected with a resistant virus because they're out there in the population. But they have to be on it forever, but they do really well, you know, people, if they take their medication.
So, I'm sorry to interrupt you.
Right.
How much is a tripla?
How much money is it?
Yeah. So one pill is, just curious.
I have no idea. But I will tell you it was free for a lot of people, like not very long ago. Yes, sir. You know it?
I've got friends that are positive. It's about $4,000 or $5,000 a month if you don't have insurance.
Oh, forget about it. So that's a problem. But, and then, you know, maybe your friends are sort of in this population. I have no idea. But, you know, people can't afford that unless you're rich. So if you're not rich and you're not poor, you're kind of like screwed. Yeah.
The patient that Dave sort of talked about that had it, that takes these pills, has had it for 10 years.
Mm-hmm.
Do they still transmit HIV to their partners?
Very rarely. If they take their drug and they're undetectable, we tell them all to use condoms. And people who are pretty compliant tend to also be compliant with sexual preventative practices also. And they do not transmit to their, they have really healthy sex lives with discordant partners.
One of the things, one of the things one of the things that we did see were people getting infected with a different strain who were HIV positive, and then so that's another thing maybe to bring up.
You know, people who have HIV, they say, "Oh, forget it. I'm not going to use condoms because I already have HIV." So the problem with that, and why we tell everybody to use condoms, is because they can get infected with a different strain and a resistant strain and dual strains, and then it basically becomes that their antiretrovirals, which are the thing that were saving their lives, don't work anymore. Mm-hmm. So everybody has to practice safe sex practices. So when do you start HIV treatment? And I'll be done in 5 minutes, so we're good. But you know, there's a whole thing here of risk versus benefit, right? And so the benefits of delayed therapy, right? Well, what if you know, I have to take tons of drugs? That's becoming less of a problem. They're expensive. I have side effects. They give me diarrhea. My lipids are going up. I had to take drugs for the rest of my life. Why do I want to start now if I'm not sick? You know, this is going to be a compliant problem. It weighs on my psyche. You know, so risk of delayed therapy are possible risk for irreversible immune system depletion, possible increased difficulty in suppressing virus later. Well, anyway, and increased risk of HIV transmission. So I guess some of it is I got viremia. Well, I can infect people. So if I'm on meds and I go to undetectable, I become less of a public health risk. Also, what about that initial stage that we saw? Does really high viremia for a long time, even if your CD4 is normal, does that actually have long-term effects that we don't know yet? And it very well might. So it's controversial. The cool thing is there was this really great study, and it's called the SMART study. And they took people, thousands of patients, and they put one in the viral suppression group. These are people who had CD4 counts greater than 350. So you should have no problems. Your CD4 is normal. I'm a normal person running around the place. They take them and they say, we're going to put you on we're going to put you on medication. We're going to suppress your virus. Okay? Do nothing but keep you on all medications. The other people, what we're going to do is when your CD4 is less than 250, because we know that's going to be a problem, you're going to start getting infections, we're going to put you on HIV medications. When you go up greater than 350, we're going to take you off because you're like everybody else. And they did this, and they saw and their primary endpoint was new or recurrent opportunistic diseases or death. That's their endpoint. And if you look, over a month, your viral suppression group did significantly different. P ratios of 0.001. They had less infections. They died less. They did better. So this was a pretty huge study because before this study, people weren't starting people on HIV meds until they were less than 200, 250, when they got close.
I remember that.
And this study really, more and more practitioners were starting to, but this study was like, listen, the people who are doing this, we got to be more aggressive. Now the guidelines are if your CD4 is less than 350, you start. And so now the controversy is, so now we're like, okay, if it's less than 350, we got a study that proves, we really got to give this, not wait until it's 250. So now everyone less than 350 started. And so now everyone's debating, well, what about if it's greater than 350? And I don't know what we're going to do about that. But anyway, these are the other situations where for sure you would do it. And it's co-infection because you don't want your co-infection to get out of control, obviously pregnancy and, other things that are related. So just to let you know, this is HIV. These are deaths in the United States. And basically, this is the 1993-94 is when protease inhibitors were made. And then, boom, there has been a dramatic decline in HIV disease. And people are really, they're just doing well. They're living and living and living. And the people that come in who are really sick are not compliant with their meds. I mean, I'm not saying it's their fault. There's a myriad of reasons why people are not compliant. But that's the reason they're doing poorly. And it's not because we don't have good meds that can keep them alive till they're 70 years old. So just to kind of give you the global perspective, because a lot of people are getting HIV meds in this country. We had great lobbying, and we had a lot of great programs, and people were getting their meds. They were getting housing, they were getting meds, they were getting a lot of services, and possibly for very good reasons. Everyone could sort of debate. But the rest of the world is not doing as well. But despite that, it's getting better. So every single year, more and more people in the rest of the world are getting drugs. So, 2002 versus 2005, and more and more, you're seeing lighter and lighter density, meaning the lighter it is, the more people are getting the HIV meds. So we are, through many nonprofits and through, the President's initiative for HIV, we are really getting a bunch of drugs there. So that's it. The AIDS virus, it's an equal opportunity destroyer.
So you mentioned that recently in North Carolina, is it working? You mentioned that North Carolina recently rescinded the funding.
Yeah.
And so I imagine every state to some degree deals with this, but are there also overlapping national funding sources? So what's the implication, across the country?
Well, the problem, well, not the problem, but it's a state-by-state program, and it really has not affected other states. So, every state is having financial difficulties, and so I don't know what other states have had to also cancel it, and I'm sure there has been, but it is really a state-by-state program, and I don't know what the national programs are, but there aren't a lot. Obviously, if you're on Medicaid or Medicare, you're going to get these funded for, but they've lost a lot. They also overrun it was like apparently it was a poorly run program, and they just went bankrupt. Like they just didn't know what they were doing. I don't know how to run a program like that. So
I have to correct myself on the monetary value that I gave you, because it dawned on me that the friend of mine's on a mail order, so that would be for 90 day. So you're still looking at $1,300 a month. But I do have a question, because I know somebody else that's HIV positive, and his body won't allow him to progress to AIDS. What causes that? What keeps his body? Really?
Well, I don't know your friend, but there's many reasons. One, maybe he's on the right. Is he on meds?
No, he doesn't have to take meds.
Oh, and
he's got it, but his body won't allow something.
So there are these genetic. There are people who have certain HLA types. Whatever. There's just some genetic types. HLA B27 is one of them. And what they do is their cytotoxic CD8 cells are more virulent at killing and keeping the HIV virus under bay. And there's major research going into who are these people whose HLA types are able to kind of keep the virus at bay. So that's usually, he probably is one of these people who has like a, I wonder, do you know if he's ever had genetic testing or anything? No. I bet he has one of these.
He's somebody that in the community, I just know, I've heard about. He's not really friends. I haven't had talked to him.
He's like a rumored hero.
You can't.
I haven't had a discussion with him. I just know from friends that know of this person. So
he might have an HLA-B27 or an HLA type that is able to where he has these really robust CD8 cytotoxic T cells that are able to kind of keep his virus in check. That's those people do well, but they still get some long-term manifestations of having disease, and they're still obviously able to transmit the disease. But that is another subpopulation. There's all this genetic studies looking at who does well with the disease and how do we replicate that.
Other questions? So thank you very, very much, Dr. Norton.
Sorry,
That's a really
I apologize.
It's not your fault. That was a very excellent walkthrough in terms of AIDS and HIV, and I think we all learned a lot. Thanks very much.
Thank you.